there are a lot of problems which happen. So as I said, fibula is our workhorse. It gives an excellent bony length to us. There is a very less donocyte morbidity, I will say. It's a composite replacement of bone, soft tissue, as well as skin. You can do a two-team work simultaneously, so the surgical time is also saved. If you have your 3D plates and reconstruction templates available, it saves more time. It's away from head and neck, so you can do a two-team approach. You can have multiple osteotomies. Dental rehabilitation can also be done afterwards. It has a dual blood supply, cortical blood supply, as well as endosteal. It's a tough cortical bone. It is straight, and graft union is also rapid. And it works well in compromised sites. And pedicle vessel is also of good caliber. As you can see here, this is a fibula flap which is contoured. And you can see that there is a two-team approach, which is very good when you want to save time. Maxillary defects, they are formidable defects definitely to reconstruct with, because challenges are formidable. Feeding, speech problems, orodontal fistulas, and veropharyngeal incompetence are the problems which we face. So the parameters we need to keep in mind is what is the skin size defect we want to reconstruct, which part of the maxillary buttress are going to be resected, which is the size of palatal defect, and is it an extended defect where orbital support will also be required to be reconstructed. So our principle is to close this artificial communication between nasal, oral, maxillary, and orbital cavities, which are created during the ablative surgeries, to reconstruct the dentition such that the function is restored as close as possible, or at least give a bony support where you can put your dentition afterwards. To restore the aesthetics by restoring the width, height, and projection of the resected tissue, as it is the maxillary prominence which is going to be very important for our functional reconstruction. As you can see, this is a good paper by Dr. Subramaniam Iyer. You should go through that. And there he has divided the maxillary defects and possible reconstructive options which you can use for maxillary defects. What is the way ahead? This is all our armamentarium which we have seen. The way ahead is 3D prefabrication. Some of us are using the 3D prefabrication for our reconstruction and virtual reconstruction before the surgery. There are customized jigs and virtual plannings available for complex reconstructive surgeries. Dental rehabilitation, some of the centers of the world are doing it during the primary reconstruction, and most of us are doing after the definitive treatment is completed. Transplantation is in the horizon, but still it is not in the literature. So something like that, if it's happening, it's going to change our scenario. These are certain papers I will recommend you to read when and how to reconstruct. That's a beautiful paper by Dr. Ralph Gilbert on the past, present, and future of reconstruction of oral cavity, and recent advances by Moni Kuriakos from our own India. And these are certain books which are helpful. I will recommend reading those books, like this is Grab's Encyclopedia. There is a very good book by Dr. Mark Kirken on defect-oriented approach, where he has identified and classified the defects and then tailor-made the flaps. And this is the local flaps by Baker. So these are the some books which you should have whenever you need. You can refer those books for your defects. Thank you.
Thank you, Dr. Dushyant. It was a very detailed description of the ways to reconstruct oral cavity defects. I think there is one question in the chat box. If you could take that, I will read it.
I think, sir, why the opposite side like fibula has been taken for recurrent case of mandible removed? Any special cause? Okay, so Loknath, I think you are asking that which side of mandible or which side of fibula should be taken for the oral cavity bony defects. Is it the question, if I understand it rightly? Same side or the opposite side?
Actually, if the mandible is affected on the right side, why we put the fibula on the left side?
Okay, fine. So if you study the fibula flap and the insetting of the fibula flap, there is only one surface you get for the plate adaptation. Now, according to the septum and plate adaptation, it is usually very easy if the defect which is of inside, then the fibula should be taken for the opposite side, because it allows free mobility of your septum and of your skin defect. So there is a paper by Subramaniam Iyer et al. If you can read that, they have given a small kind of an mnemonics that I know I. So inside no ipsilateral. If it is outside, you can take same side, but if it is inside, if you take contralateral, the contouring and the inset of your skin flap and the range of mobility of your skin flap increases a lot if you are putting it on septum. At the same time, I will like to tell that if you are actually dissecting your perforator a lot, and if you are trying to make it as a chimeric flap, perforator separate and your bone separate, then you can take it from any of the sides. But so usually for inner defect, ipsilateral is not taken because opposite side gives a better pliability of the tissue.
So thank you, Dr. Dushyant. I think there are a couple of more questions.
Okay.
You would like to
I
take
think,
them?
yeah, Krishna Gopal Birmiwal. I think he has a question.
Yes, something about scapula free flap when you consider doing it.
When you consider doing it. Okay, so most of us are very kind of well versed with fibula flap. There is nothing against scapula flap. First thing which I will like to tell you is that use the flap which you are comfortable with. Now, scapula flip, when you consider doing it, one is that the defect is there and you do not have a fibula with you, right? Many times you have a person with a road traffic accident, you do not have a fibula to use. There is a person with polio at both the limbs, and the fibula is really hypoplastic, or you have used your fibulas before. At that time, you will definitely use scapula free flap. In pediatric patients in the palatal defects, you will like to use scapula because there is a germline center there that fibula will grow with the palatal growth and will cause less deformity. So you will like to use scapula in those pediatric age group of patients also. Many of the centers of UK are using extensively scapula rather than fibula, but it is the choice which you have and what you are comfortable with. There is one question by Vasant Raj. If we want to preserve the commissure, how close can we take the incision in the face to maintain competence? Vasant Raj, now taking the incision is not in our hand. I will say whatever the oncological safety is, you have to cut. So you have to remove whatever you have to remove, and whatever you are left with, you have to do best of it. So I think we do not have in our hand how close we take the incision to maintain the competence, right?
So my doubt actually was In case of a posteriorly located lesion, like if the location is going to be, if the lesion is going to be sitting on the RMT and just involving the molars. So,
Right,
and in that case, I don't want to split the lip. So, making
right.
splitting the lip is obviously going to make my life easier while taking the while trying to do the resection or trying to restitch it up. But I want to know if that is obviously going to spoil some amount of the competence. So I want to know how close can I go towards the commissure without compromising the commissure, because by improving my exposure, my surgery is going to be a bit more easier.
Okay, so Vasant, I think your question has two subparts. One is that it's an posteriorly located lesion where you do not want to cut your commissure, and
Yes, sir.
here what we do is we do it's an intraoral as well as neck approach. We do not put an incision on the lip, or we do not do a lip split. So if you are well versed with that anatomy, you can do half of the resection or half of the cuts from intraorally and half of the cuts from the neck, and you will be able to very easily and oncologically safe resect the entire specimen. You will not touch the commissure, and the problem of incompetence will not come. At the same time, uh, as commissure is important, the modulus is very important. Modulus is something which is situated around 1 to 1.5 centimeter lateral to your commissure, where all the muscles of face or muscles of the and the modulus is the one which is very important for the competence of the oral cavity. So, if possible, remain around at least 1.5 centimeter away from your angle mouth to preserve the competence, even if you want to put your incision there.
Okay, sir. Yes, sir. Thank you, sir.
Yeah. I think there is one more question. With Ankit. Ankit has asked, can fibula flap be the ideal reconstruction for a patient with polio? Had a patient which needed bone reconstruction, inevitable middle one-third defect. Yes, Ankit. So this is what I just covered in regards to the scapula flap also. So if the fibula is really hypoplastic, it is not going to serve your purpose. Though you will think that taking a fibula is not going to add any morbidity to the polio patient, but there will be a lot of hypoplastic bone and the muscles will be really very hypoplastic. So using that compromised bone for the middle one-third defect is really going to be tricky. Rather, you should think of other avenues of bone reconstruction like scapula.
So thank you, Dr. Dushyant. I think I have only one question, Dr. Poonam here.
Yeah.
So normally when we operate lateralized mandibular lesions, most of the time, like the lesions which are involving the lower alveolus or the RMT, when we don't have facility for fibula or the ideal reconstruction, we end up removing the condyle. So this is a very often question asked by our resident, that can we leave behind this condyle and later on after radiotherapy, if it is possible, it can be reconstructed. So what is your take on that? Normally at our institute, Tata Hospital, where the waiting list is very high, we end up doing a lot of PMMCs for lateralized mandibular lesions. So
Right.
can we, yeah.
Yeah, I agree with that. That for a well lateralized defect in a busy setup, and if the patient is not willing, PMMC is not a bad option. We like to add that in the patients with severe submucous fibrosis and trismus, even if you reconstruct a lateralized defect with fibula, the patient is not going to have much of the advantages of fibula. Rather, a soft tissue will help the patient to have some mouth opening. Now the question of leaving behind the condyle. If the your oncological resection doesn't need a resection of infratemporal fossa tissues, let's say lateral pterygoid, etc., then leaving behind the condyle is okay. There is no, if it is oncological safe, you can leave it there. There are only two issues that if the patient is going to receive radiation, etc., and he's going to have a lot of fibrosis in that area, the condyle is going to be kind of stuck and it will go superiorly with the fibrosis. So the secondary reconstruction, if you want to go for a secondary reconstruction after that, it will be very difficult for you to really relieve the condyle from that fibrotic area. So it will be really tricky. If you can at least preserve the posterior part of your vertical ramus of the mandible, 2 centimeters, do a segment, and then posterior part, your suture medial pterygoid and masseter anterior to that part of the mandible. And balancing force, it will not allow that segment to ride in the infratemporal fossa, and it will allow you to have a bony reconstruction postoperatively. So a small condyle, if it is left behind, it will get fibrosed, and you will find it very difficult to retrieve it if you want to go for a secondary defect.
Thank you, Dr. Dushyant. I think there are 2 or more.
Yeah. So I think we have how to reduce detachment of PMMC flap from the upper alveolar end. Can Bhushan, can you be more specific about your question? I'm not able to understand you.
Sir, when we attach the PMC in the lateral buccal defects, and PMC gets detached very commonly, sir, by us residents from the upper side. That means
okay, so it's like post-operatively the PMMC falls off from the upper alveolus, right?
Yes, sir.
Okay, fine. So I think there are 2-3 things which you need to take care of. One is that if you take a PMMC of a good bulk and length, then what you can do is the distal portion of the PMMC, which is going to the palate or upper alveolus, you can deepithelize a portion of that, and which can buttress the soft tissue. You can take few sutures of the deepithelized portion with the soft tissue around the upper alveolus, which will act as one more layer of reinforcement. Second thing which you can do is, if the flap is very bulky, you can put certain holes in the upper alveolar bone and take your proline sutures, big proline sutures, so it will allow it to hang. Specifically, whenever there is a maxillary defect there, whenever the sinus is open, this usually happens. So I usually advocate that take a lot of soft tissue or deepithelized portion in the distal portion of the PMMC, fill it inside the maxillary cavity, and take few sutures. That usually helps. We have a question by Sikhar. He says that, what would be your reconstruction of choice for a partial maxillary defect? Will you prefer an obturator if the opposite canine is also preserved, or would you want to close the cavity with a local flap-like temporalis? Okay. Now, Shikhar, this is an interesting question. If the having a support can be given to the obturator, and if the defect is posteriorly and very well kind of an local defect, obturator is not a bad idea. So if you can give good support, an obturator can be offered to the patient. Now, if the patient is having trismus, the mouth opening is low, and the defect is posterior, even if you have 3-point support to your obturator, the patient will not be able to put obturator there. In that case, I will say that rather than putting an obturator, a temporalis is a better idea.
Thank you, sir. Sir, one more doubt regarding this. Till what extent of partial maxillectomy would you still consider an obturator? Like, for example, if I have gone higher up and even cut the zygoma, will you still prefer like be okay with an obturator, or in that case would you want to do a flap?
if the defect is having a height, let us say it is going up, it is we have removed entire lateral maxillary wall, anterior maxillary wall, or even the supports to the eyeball or part of zygoma, then the preferable reconstruction will be definitely a bony reconstruction. But at the same time, I would like to say that with a good mouth opening and with now good prosthetic people available with us, we can have a prosthesis which will go inside like a bulb and will allow expansion of that area also. So a good prosthesis can take care of that also. So I think it will depend upon how good your prosthetic people are, and it's still not a bad option if the mouth opening is going to remain good.
Thank you, sir. Thank you.
We have one question from Bhushan. If neck flaps get necrosed and DP is not sufficient to cover them, and we are not sure of trapezius flap vessels, what would you suggest to cover the row area with it? Definitely interesting question. So as you are saying, DP is not sufficient, I think that you are not thinking of a PMMC, spiral PMMC, Bhushan?
Sir, PMC was used for the oral cavity defects.
Okay. I think then it's a very tricky situation, and the short answer will be to do a free flap and do your anastomosis in the opposite neck. That will solve your all the problems.
Okay, sir.
Yeah.
So thank you, Dr. Dushyant. I think it was one of the most interactive session of our series, and I thank you for your patience in giving each and every answer, and thank you, sir. It was an excellent presentation, and we would request you to be available for our future classes on Saturdays as per your convenience.
Thank you, Dr. Poonam, and thank you, Tirtha. It was really interesting to see a lot of questions and very practical questions, and I was happy to answer them. Tirtha has my numbers and my contacts also, so you can circulate that. If you has any question regarding to reconstruction or any head and neck questions, you can definitely come back to us. Thanks a lot.